to it. The next part of our program will of course be our keynote presentation and discussion. So I will now hand it over to Ruth Katz, who will introduce our keynote session for today and will also be moderating the discussion portion of the session.
Thank you so much. Appreciate it. It is now my great pleasure to introduce today's keynote speaker, Kassandra Frederique, Executive Director of the Drug Policy Alliance, a national nonprofit organization that works to end the war on drugs, a policy that has disproportionately impacted Black, Latinx, Indigenous, immigrant, and LGBTQ communities, and instead build alternatives based on science, compassion, health, and human rights. Her own work, as well as that of the Drug Policy Alliance itself, lies at the intersection of health, equity, autonomy, and justice. Kassandra's advocacy has been highly effective. She has mobilized cities to rethink their approach to drug policy from the ground up, and has been instrumental in structuring the national drug policy conversation around reparative justice and restitution for communities harmed by the war on drugs. The recipient of numerous awards, Kassandra has been featured in the New York Times, MSNBC, USA Today, NPR, and the Netflix documentary, Grass is Greener. She holds a master's degree in social work from Columbia University, as well as a BS in industrial relations from Cornell University. Kassandra, thank you so much for taking time from what I know has been an incredibly busy time for you to join us today. It's really terrific to have you here. We're eager to hear your presentation, after which you and I will have a brief conversation. The stage is all yours.
Thank you. I want to thank so many of you for allowing me to come in today to be the keynote speaker for the day. A special thank you to Dr. Hansen, who suggested me. We've done amazing work together in New York around race and overdose, and so grateful that she would extend this opportunity to me today. So Aisha, you can start the slide. So this is a different presentation that I'm sure you are used to. I am very much an advocate and organizer, protester, and what Aisha asked for me to do was to come here and talk about actionable strategies around racism, opioid use, and addiction treatment. And when I talked to Dr. Katz earlier this week, she said, tell people who you are, and then make sure you teach something and give us things to do. And so I'm going to do what I know, which is to charge the audience with what you need to do. And I am not going to pretend to be objective because I'm a Black woman in America. And I think the illusion of objectivity does more harm than good, especially when we're coming to issues of health and incarceration. So my question here is, which side are you on? Dr. Victor opened up this conversation in an amazing way that really lays out some of the things that I hope to talk about here today. But one of the things I want to be really clear on is that our work is not neutral. Our work is either upholding certain things, reinforcing things, or it is disrupting things. And I think that one of the biggest reasons why Dr. Hansen asked for me to join us today is because I would like to disrupt certain ideas that serve as the underpinnings of the way that we approach medicine, the way that we approach research, and as the way that we approach issues surrounding drugs. And so my presentation is called, Which Side Are You On? Race, Overdose, and Power Building. Next slide, please. I want to be very unequivocal about this. Race is the foundation for all the work that you're doing, not just in the Opioid Collaborative, but in all the work that you're doing around. There are two people that really underpin a lot of the work and build a lot of my thinking. The person on the left is Troy Duster. Troy Duster is a medical ethicist who does a lot, who has written seminal work around genetics and race. But one of the first things that he started out with is this book that he wrote in 1969 called The Legislation of Morality, Law, Drugs, and Morality. And the major thesis of this book was that drug laws are not based on the pharmacology of the drug, that our laws that govern it, the practices that govern it, are based primarily on the perception of the dominant user population. He used 100 years of evidence of drug laws to make this thesis. I think it's very important for us to acknowledge that this book was published in 1969, 2 years before Richard Nixon declared the war on drugs, which will have its 50th anniversary in June 2021. And part of the reason that he came up to this is because the drug laws are always associated with people who are not white. So the opium laws were propagated by the fear of Asian people. The marijuana is called marijuana and not cannabis like the rest of the world because the US government and the media used marijuana, which was the word that Mexican folks in the Southwest called it. And they used it as a part of racialized propaganda to build fear around Mexicans, but also around also around the substance. Marijuana was also used to target Black jazz folks in the Northeast, where there was a lot of integration happening in jazz clubs. If we think about heroin, we also consistently think about Black folks. If we think about the difference in disparities in the way we've treated cocaine and crack, again, propagated by the role that race has played in the defining of the narrative associated with it, which has subsequently impacted the way that we build our health responses around it. And I think most people, when I come into the room and I talk about how drug policy in general is shaped by race and class, folks can get with that. But in this audience, I think it's also really important to recognize that the institution of medicine is also shaped by race. And this was also part of the seminal history that Harriet A. Washington wrote in her seminal piece, Medical Apartheid, The Dark History of Medical Experimentation on Black Americans from Colonial Times to the Present, which was published in 2006. And part of the reason why I'm starting my presentation this way is because I think it's truly important to realize that the work that you're doing is not in a vacuum. The work that you're doing is either upholding principles of white supremacy or it is disrupting it. And for the most part, people can do both, and they do both at the same time. And what I am imploring folks that are listening to this presentation is understanding that even in the way that we have shaped our response associated to the growing overdose crisis, largely reinforces the pillars of white supremacy and the role that white supremacy plays in policymaking and health interventions. Aisha, please, next slide. And there's no greater way that we see this than in the way that we talk about opioids, in the way that we talk about the current overdose crisis. 2 weeks ago was the 5-year anniversary of this front page story in the New York Times, in which it says, in heroin crisis, white families seek gentler war on drugs. This article, when it hit the stands, was infuriating. Policymakers and researchers and academics and physicians and health providers all stood with their mouths agape because never has it, well, not never, so recently to be so clear about the role that race was playing in the way that we were responding to the current overdose crisis that we were navigating. Important to note that even in the first part of that sentence, it talks about in heroin crisis. This is important because I think what's often missing from the conversation about the overdose crisis, which consistently upholds the issues of structural inequities, is the fact that it focuses on one kind of drug, opioids. In fact, your collaborative is called the Opioid Collaborative. And despite what we know, that overdose is usually contributed to a mix of drug toxicity. And that often what we also know from research is that most drug use is poly, and that people buy drugs that they can afford. And while they may have preferences and they may use some more than the other, oftentimes what we're dealing with is a drug poisoning issue. But focusing on heroin at the expense of methamphetamine or stimulants, it really shapes and curates and culls the ability for us to have a comprehensive approach which actually deals with the broader set of issues of social determinants of health, which serve as risk factors when we're navigating overdose. And then still in this sentence, you see when we use white as the modifier for families, that it is only a certain group of people that can engender a front page story about why we must respond in a different way to a growing health crisis. This is critical because we have to think about who is able to sound the alarm, whose calls are the ones that we are most willing to listen to, and how do we move into a place where people have the same access to resources and education in a way that keeps keep people alive and creates the ability for communities to thrive. And then the third part of the sentence, a gentler war on drugs. This inherently shows that we understand that the drug war as it has a disproportionate detrimental impact on communities, that it is too blunt of an object tool to impact the way that we navigate addiction and people. Now, this sentence may not seem to be relevant to the folks on this call. Based on my conversations with Aisha, you all are health providers. You are in the helping profession. You are navigating, you understand the way that race is playing into this. And you also understand that this moment is less about politics and it's more about getting people the help that they need and deserve. Next slide, please. But I want to implore you, how much has race shaped our response? Not only is the media putting forward a framework in which we are all responding to, even the data doesn't bear out what we know. So a recent study around opioid involved overdose deaths trends between 1999 and 2017 by race by Drake et al. Found that while nationally overdose rates remained stable for Black and Latinx communities for the beginning of the crisis, they steeply increased in 2012 and 2013 and onwards. This graph is a good visual to keep in your head as we think about how we navigate this. Why is it, despite the conversation and what we know, that in 2015, the New York Times will talk about the white heroin crisis, which is also flooded by the media portrayals of white folks suffering. And it's not just white folks, it's white folks with means. So folks from upper middle class who are struggling with addiction, which is engendering a national conversation about understanding that our response is not appropriate for the things that we are navigating in this moment. And this public narrative has also shaped the way that we are even dealing with this. And so part of the reason that I think this is important is because, you know, in 2007, 40% of all Latinx overdoses involved fentanyl. 31% involved heroin and 26.8% involved cocaine. And while between 2017 and 2018, total drug overdose deaths actually went up among whites that year, drug overdose deaths remained stable among Black people in that time frame, and they actually increased among Latinx people. Cocaine involved overdose deaths increased for both Black and Latinx people between 2017 and 2018, while they stayed stable for white folks. Methamphetamine overdose deaths increased for all racial ethnic groups between 2017 and 2018. Part of the reason why I think this is crucial to bring up in this moment is because it goes back to what Dr. Victor said at the beginning, which is how do we build a response that is that can work for other drug crises? And what I would challenge is that how do we build a response that stops new drug crises? How do we build a response that's actually built in poly drug use? And if we are in a moment where we're trying to build racial equity in the way that we build health interventions around an overdose crisis, and we see that overdose is going up amongst communities of color when it comes to stimulants, why are we still building drug responses based on mono drug use? Why isn't the opioid collaborative a collaborative around overdose that looks at poly drug use and moves it forward. And I think part of the reason is because of what we already know and what research is available and what health interventions we have around stimulants is not as developed as what we know works for opioids. And I think part of that is because the interventions that we have for stimulants often are rooted in agency and self-determination for the people that use them. When it comes to opioids, we can build metrics and build research grants around things that fit into our ideas of public health. And while those are things are important, none of that disrupts the way that race is being how the way that race is being used as the foundation in the way that we build our interventions. None of that disrupts the way that people of different socioeconomics, people of different races, people of different genders, people of different sexual orientations, people that are living at the margins of society, those that are being suffocated by structural inequities, are navigating and experiencing this health crisis. Next slide, please. All of this was happening before COVID-19 happened, right? I'm talking about the fact that overdose among stimulants was rising in 2017 and 2018, way before COVID-19 was even in our ethos. But when we're looking at the conversation about navigating a racial equitable response to COVID, when we're seeing headlines talk about who has access to supports, who is surviving COVID-19, we see that the same racial disparities exist, the same socioeconomic statuses exist. And that should give us pause to understand how is COVID-19 exacerbating the already underlying issues that we are fighting. If we map who the communities that are being most disproportionately impacted by COVID-19 and map the kinds of people that are disproportionately being exposed and dying from COVID-19, we will see striking similarities. But to you who are in the fields every day, none of that is surprising to you. The social determinants of health, the structural inequities that uphold and exacerbate the impacts of a global health pandemic like COVID-19 is not surprising to you. It's also not surprising to you that what we are finding is not only is overdose rising again after a brief relay, it is also being exacerbated by COVID-19 for when people are home by themselves, unemployed, dealing with stressors, the mental health obstacles associated with navigating COVID-19, as well as the issues associated with structures and being able to support people are things that are being exacerbated. And we're navigating two health pandemics in one, and race and class and structural inequities are shaping it all, are really playing a magnifying multiplier effect on the way that people are able to make it through every single day. This compounded by the summer of an explosion of social unrest, considering the role that criminalization and policing and law enforcement plays, is crucial. And I think it's important to consistently put criminalization as a factor in the way that we navigate overdose in this country, because it also shapes who we are serving. The last time the Department of Justice put out a study on deaths in jails and prisons was 2016. And then we knew in my home state, New York had the 5th highest overdose rate in jails. And that to me was striking, because oftentimes we use incarceration as a way to deal with navigating drugs. We use it as a way to try to control people's behaviors. We think criminalization is a deterrent. And it's not just that these kinds of carceral punitive policies and regulations are happening in jails and prisons. They're also happening in our healthcare facilities. They are also happening, these are the same underlying stigmas that happen and that are present in practitioners. And, I think it's important for me to elevate the ways that we reinforce that in the way that we build the interventions, but also in the ways that we build our studies, the way that we build the work that we do forward. And part of the conversation is understanding that, Reuters talked about the substantial rise of deaths in this country's largest jails around overdose. And we know that overdose is one of the leading causes of death when people leave incarceration. But I think the biggest thing that I want to offer this audience is that when we're thinking about interventions, when we're thinking about race, we have to be thinking about power. Racism is about power. And as we build the opportunity for us to have these conversations, are we building power with the people that are dying and that are struggling and that are marginalized by the institutions that we work within? And that also means figuring out where we stand in the complicit relationship between punishment and care, and understanding that it is crucial for physicians, doctors, and nurses to understand what does it look like to increase agency among people who are dying, among people who are navigating health disparities, among people that are currently at the crosshairs of overdose, race, COVID-19, and power. Next slide, please. And that means the opioid collaborative cannot be neutral. We have to pick a side about what we are disrupting. It cannot be, if we are committed to racial justice and racial equity, it cannot be that we are working solely to end the overdose crisis. We have to be working towards ending the structural inequities that serve as risk factors for the overdose crisis, for COVID-19, for disproportionate policing in communities. We know that incarceration is not good for people's health, but we have not made the decision that we have to disrupt the ways that punishment, stigma, and surveillance serve as underpinnings in the way that we build interventions to modify behavior. Next slide, please. And so as we build, as we continue to build social justice as well as health policy principles in our work in navigating COVID-19, Drug Policy Alliance has put out policy principles that I'm sure underpin the work that you do in the collaborative, but I want to reinforce them here. How do we address structural racism and systemic inequities in the way that we build the interventions? How do we ensure access to benefits and services regardless of immigration status? What are the ways that we can create loopholes so that we can serve more people? How do we reflect the differing needs of communities across the country? Here again, I consistently say, while overdose using opioids is overwhelmingly what we're seeing and what we're responding to, there are parts of this country that need this kind of infrastructure for different kinds of drugs, especially for stimulants. And we should be considering and challenging the way that we are building mono drug use responses. And then we have to build the research to back it, building out broader health interventions that deal with issues that for the most part, folks in this discipline have been discouraged on weighing in on. Researching and measuring the social, racial, economic, and health impacts of COVID-19 and policy responses to COVID. I think part of the reason why I think this is important is because those factors are making your work around the overdose crisis more difficult. And what are the things that the federal government has done around increasing access and removing barriers to treatment like methadone and buprenorphine that we can continue to keep in place after the crisis? This is about increasing agency. These are some of the suggestions that people that have used drugs have asked for decades. Next slide. The other thing that I would offer is, how do you use your research as resistance? So much of what we know and so much of how we talk about drugs is in the spectrum of drug abuse. And what we would offer is that drug use is along a spectrum. Most people that use drugs do not end up in your care. They are not using drugs problematically or chaotically. They are using drugs in their everyday lives and are still able to thrive and be great citizens of this country. And then there are people that struggle. But all our research and all that we know is based on the slant towards abuse. And that limits the way that we can think of different interventions to engage with different communities. This also has a very chilling effect on the way that we can deal with drug use through a racial equity lens, because how we think about it and how we talk about drugs right now really reinforces this idea of the accidental addict, which gets to the point that white communities were never supposed to be dealing with drug addiction in these ways. And part of the reason why we're marshaling all these resources is because this was a mistake. And this reinforces the idea that Black, Indigenous, and Latinx people were always going to deal with drugs because of the way that media and research talks about talks or doesn't talk about the role that race plays in shaping people's experiences around drug use. Next slide, please. And that means taking into consideration the way that we refute bad or misleading research. This is super important. We know that naloxone saves lives, but advocates had to take a lot of time navigating research talking about the moral hazards of mainstreaming naloxone and how it was sending a bad message. We had to spend time doing that as opposed to doing the political education that is necessary in our communities to move forward. And I think that's really important as y'all build health interventions as well as research questions, is really understand that research is not neutral, that research impacts people's everyday lives, and that you are responsible for what you put out into the world as much as the media. Next, please. Next, please. Next, please. And that means, how do we use your platform? How do we democratize the knowledge and the skills that you have to amplify the voices of people that are currently struggling with addiction or the family members of those who have died? Drug use is pathologized by racial and class lines. And so that means that if it's pathologized in the media, if it's pathologized in the research, that means that serves as an underpinning of the way that you navigate and you deal with people who use drugs. And we know this because informal health systems, harm reduction, is an informal health system that is doing everyday interventions, saving the lives of people who use drugs, who feel too marginalized to be a part of traditional health systems. And that means your side has to overcompensate by investing in the informal health systems that are working for marginalized communities in this moment. As the traditional health systems were inundated with COVID-19, informal health systems like syringe exchanges, like harm reduction organizations, jumped into action to navigate how to deal with COVID-19 among people who use drugs, who were not engaging the health interventions that we have currently. And that this means that we have to invest, that it's not that communities have to come to you, but that you have to go to community. Next slide, please. And that means sharing policy, shaping policy with community. Drug Policy Action, which is the political arm of Drug Policy Alliance, had an amazing Tuesday. Last Tuesday, we legalized cannabis in 5 states, or did medical cannabis in one of the states, including in the deep south of Mississippi. But we also decriminalized drug possession in the state of Oregon, and use those resources from excess marijuana tax revenue, as well as diverted law enforcement resources to invest in treatment facilities, but not just traditional treatment, in housing, in harm reduction, in employment supports, understanding how do we get resources to the social determinants and the risk factors that we know are upholding the overdose crisis, but also by empowering Black and Indigenous Oregonians to make decisions about where that research goes, what are the questions we want to ask, how are we going to evaluate it, and how are we going to push forward disrupting the relationship between care and coercion. Next, please. Next, okay. And that means building power with communities. And so what does it look like for the Opioid Collaborative to do more in communities in different parts of the country to move things forward. How do we do that? And one of the things is finding like-minded researchers that do this information. At Drug Policy Alliance, next slide, please. At Drug Policy Alliance, we have a Department of Research and Academic Engagements where we deal with addiction doctors, we deal with researchers, and we figure out ways to democratize the way that we are going to build information about overdose, not just opioids, but also build power among communities of people who use drugs, communities of color, to build the interventions that are crucial to our survival and our success. Next slide, please. And I will end here with George Floyd, who emphasized and brought things forward. Many people ran to the streets to protest about the unjust killing of George Floyd at the hands of law enforcement. What many people have missed is that George Floyd was originally ensnared in the criminal justice system because of a drug possession arrest. George Floyd was also in and out of treatment for opioid addiction. His life was ended because of the attention of his skin, but also because of law enforcement's familiarity with him. It all started with a drug arrest. It all started with drug treatment. And I think one of the things that I'm imploring the collaborative to think about when we talk about race, overdose, and power building is understanding that you too have a role in disrupting the ways that in disrupting the barriers that impede people from getting your care, and also examining the barriers that you espouse when navigating people that are struggling with addiction across racial lines. This means we need to have a conversation about what it means to increase agency, remove criminalization, and policy suggestions like all drug decriminalization and safe supply, as they're doing in British Columbia, need to be part of the conversation that you're having in the next 2 years. Thank you.
Kassandra, thank you so much. Wow. First of all, you did exactly what I asked. You told us who you are and what the Alliance does. You taught us a ton of stuff, and you gave us some ideas on what we should do in terms of going forward. It really was just terrific. Thanks so much. We're short on time, but I do want to get in a couple of questions if everybody will bear with me. There's so much to cover here. In terms of addressing the issue of structural racism, I don't think anybody listening in today would disagree. This country is a major problem that we've got to address. But I think you would also agree that addressing structural racism across the board is going to take a long time. It's not going to happen overnight. It's not going to happen in a year. What recommendations would you have for short-term ideas, action items that we and the collaborative specifically could take to address this issue from an opioid epidemic point of view, but even more broadly from drug problems in general? What interim steps could we take to try and address this issue?
I think one of the biggest things that folks can take right now is democratizing the way that we build interventions. I think that folks here need to get out into the community in a more meaningful way in dealing with people who use drugs. And part of that is because they are navigating the structural inequities that our interventions aren't taking into consideration. And so, with COVID-19, as we navigate, we had to navigate increasing access to take homes for methadone. We had to really lean into telehealth and telemedicine. All of this was about reducing barriers, but I think this is also about reducing stigma, right? And increasing the agency of people who are using drugs. Methadone is highly restrictive, and the stigma associated with methadone is highly racialized because we see the disparity in who is prescribed methadone versus who is prescribed buprenorphine. And I think it's really about figuring out how can we work to deal with those disparities in prescription, as well as working to figure out how we can get medication in jails and prisons, as well as in the hands of community health clinics.
So you brought up the issue of stigma. This is an issue that, as you know, as Dr. Zhao said, we've got 4 working groups. The issue of stigma applies across the board. It's one that the collaborative has been looking at across the board. How do we deal with it, both from an organizational point of view? As you noted, we've got a lot of health professionals. How do those organizations deal with it? But how does the individual practitioner on a day-to-day basis begin to try to address that problem?
So here I would say I'm not actually the best person to talk to about that. There are over 30 drug user unions around the country. These are user unions, organizations of people who use drugs, who are organizing to build power and to build policy. And I would actually encourage the Opioid Collaborative to build partnerships with drug user unions across the country to talk to people who use drugs and ask them how individual practitioners can reduce their stigma and improve their practices. And I think this is crucial because we have come such a long way in dealing with impacted communities. And I think that the work has been aided and grown by building more space, active space for people of recovery to be in conversation and leading policymaking. And what I think we need to do is take it a step further and actually engage people who are currently using drugs, who are currently in the market, who are currently using these interventions or not using these interventions, and talk to them about what is necessary to improve people's individual practices as well as our organization practices. And that goes from everything from the way that you engage your bedside manner. It goes for the language that you use. It goes in the way that you build partnership around how much medication you offer people. And it goes into the fact that treat what people are asking you to treat, not what you think they should treat. Oftentimes, individual actions by practitioners reinforce stigma and then that tells people not to come back. And I say that as a social worker who understands the role as a care practitioner who is taught certain things and is often taught to look out for things around risk management and reporting. And my license can be on the line. And so that actually is prioritized in the everyday interaction with the individual. And that happens disproportionately to women and to people of color.
So my time is just about to run out, and one of my jobs is to try and keep us on time. So let me conclude with this question, put you on the spot just a little bit. 2 things, and to help our audience. Is there one thing from your presentation a concept that you want our audience to take away from your presentation? That's part 1. And part 2, if there is just one, I'll give you 2. If there's 1 or 2 action items you could suggest to our group, what would they be? So what's the big concept, and what are a couple of action items you would say, if you guys can do anything, this is it, and do it now?
Okay, so I would say, that's a big question. So I would say a concept that I think that the thing that I think that folks can do right now is to partner with harm reduction organizations. I think that harm reduction has built an informal infrastructure for people who use drugs, and they're doing comprehensive care around this country, and they're underfunded, they are under-researched, they are under-supported. And I think that organizations like the National Academy of Medicine need to work with organizations that are happening around the state that are serving this community and figure out how to strengthen them. And understanding that it's not strengthening them to be better interjected into the health system as we are right now. I think I would argue that what we have right now is not enough and that we need a new system. And so I would take that as working with harm reduction agencies to actually build a medical and healthcare system that is based on people as opposed to control and the subjugation of others. And then the second thing that I would say, the major takeaway is interrogate your biases and the things that you think about. I would offer folks to consider what it means for us to understand that you are not the main experts, that there are experts happening in the community, and what are the actions you can take to democratize expertise in the communities that you serve.
Terrific. I'm sorry we're out of time. I could have gone on and on and on, and I know how busy you are. Thanks so much. This was terrific. You got us off to a great start. And most importantly, you've given us an awful lot to think about and an awful lot to do. Thanks again. I shall turn the program back over to you.
Excellent. Thank you so much. What a powerful presentation and engaging follow-on discussion. So thank you both. Thank you, Kassandra and Ruth. Kassandra, we really appreciate you taking the time to be with us here today to share the importance of your work and its intersection with what we do. We applaud you for the work that you're doing to advance health equity, and you have certainly reaffirmed for us that we still have room to grow, and we hope that through our work we can contribute and make a difference. We are at the end of this session for now, so we will transition to a short break before introducing the next part of our program. And we'll reconvene with everyone at 10:10 a.m. Eastern Time. Thanks so much, everyone, and see you in a bit.